Hello, welcome to Derek Strate's Palpation Final. I'm Derek. This is Michael Hardy, my patient.
Cool.
Michael, I am going to be orienting myself on some structures to try and figure out what's going on with your pain that's everywhere in your body today. So I'm going to have to palpate around your shoulder, knee, hip, kind of all over the place. Are you okay with that?
Yes.
Cool. All right. And as part of that, I'll probably have to have you move up your shirt a bit, or maybe pull your shorts down a bit. Are you okay with that?
Yes.
Cool. So can we start with you moving up your shirt a little bit then?
Yes.
Let's jump right into this. And I'm going to slide your shorts down just a little bit. Is that okay?
That works for me.
All right. So first, I'm going to go right here. Yep. So there's the anterior superior iliac spine. This is important because it's an origin for the sartorius muscle and the inguinal ligament. It is also an easy spot where I can move slightly kind of posterior laterally, and I'm on the tensor fasciae lata muscle, which is close to the IT band, which is a common tightness spot for a lot of people. We're going to go up by Michael's ribs up in here, and we're going to try and palpate his liver. So if I can find the 12th rib, it's right in here. And if I push down, Michael, can I have you breathe in and out for me, please? Okay. So I can feel that kind of hard spot right in there. Can I have you do that again, please? Yep. That's where his liver is. The liver should be like a more solid, hard structure. It shouldn't be tender. If it is, there's something wrong with the patient, and that you should advise that they get it checked out. And it's also a good spot to orient yourself with the costal cartilage and the ribs 10 through 12 right here, because they don't connect directly to the sternum. Now, Michael, can I have you can pull your shirt down. Can I have you pull your shorts down as far as they'll go? Perfect. Have you bend your leg up just a little bit? So now I'm going to be looking for the medial femoral triangle, which is bordered by the sartorius muscle, which comes from the anterior superior iliac spine down to the medial knee. The adductor longus, can I have you push against my hand? Yep, right in there. You can relax. There's the adductor longus. And then the inguinal ligament, which is up in this area, up where the pubic symphysis is. Yep, right in there. So the medial femoral triangle is right in this area. And this spot is significant because you'll find the femoral artery, vein, nerve, and some lymph nodes there. All right, we're done on your back. Can I have you roll to your side facing the wall, please? And the one structure I'm going to palpate here is the greater trochanter. Greater trochanter right there. Greater trochanter is important because it is an insertion point of your deep six intrinsic hip external rotators. It is also a spot of common pathology, obviously, then, with tightness and soreness, and also your hip abductors, your glute medius and minimus will go there as well. Can I have you lie on your stomach now, Michael, please? So I'm going to move your shirt up a little bit. Is that okay? Perfect. Probably pull the shorts down just a little bit too. Now we're going to be finding the posterior superior iliac spine. Right in, let's see, right in this area. Yep, right in there. Posterior superior iliac spine is important to know where to find because your gluteus maximus will originate from there in that area. It's also level with the S2 vertebral vertebrae. So if I move just slightly medial where the spinal cord is, I can feel kind of a harder spot in there. That's where the S2 vertebrae is. So now that I'm on S2, I'm going to slide down the sacrum until I feel the sacrum kind of dip medially right in here. Sacrum being kind of what everyone calls your tailbone. This is where your ILA is, your inferior lateral angle of the sacrum. Again, this is a spot where gluteus maximus kind of will wrap around in here. And if I really want to get right to the bone, I have to push really deep on this spot. And again, spot of pain commonly in a lot of people. Next, we'll be moving over to the ischial tuberosities. This one can be kind of tricky to find, but once you find these gluteal folds down in here, you can feel kind of a harder end feel medially. As you kind of go up in there, you can feel the ischial tuberosities. These are the bones everyone likes to sit on, and they're big, strong bones. They're the origins of the hamstrings. They're also a spot where ligaments will attach, like the sacro tuberous ligaments and other ligaments that help stabilize your hip. Lastly, while you're on your stomach, Michael, I'm going to do your 12th rib first. So kind of up here when I was looking for the liver when you were on your back, now you're on your stomach. I'm going to come right in between the iliac crest and just superiorly to that. So where the 12th rib is, I can feel that right there. This is a floating rib. And this is important to find too because it will help you orient yourself with the quadratus lumborum, which is a muscle between your 12th rib and your iliac crest. And it's also a good way to find iliac crest, as I said, going the other way. You can also follow it back to the spine to find T12. And then lastly, we're going to find your L5 spinous process, which sliding up the back is going to be the most prominent lumbar vertebrae. It's right there. It's easy to find because you can just feel along and just find it right there. L5 is a very common site for lumbar disc herniations, so lots of low back pain there. So I'm here with Michael again. He is now seated with his shirt off. We're going to start with the knee joint line. So you start here, find kind of where the patella and the patellar tendon is. You can kind of go out. The knee joint line is important because underneath my fingers right here is where the menisci will be. And as you go out medially and laterally, you'll have the medial collateral ligament on this side and the lateral collateral ligament on this side. Now that I'm on the lateral side, the fibular head is right here. The fibular head is where the common fibular nerve runs around it. So if people have problems with that, you can palpate it around that area to find out. It is also the insertion point of the biceps femoris muscle. As we go down, following the tibia, we're going to get to the talus bone once the tibia ends. So right in here. Now if I have Michael point his toes to the sky, it goes away. If I have him point him to the ground, plantar flexing, it exposes itself. The head of the talus is a common site of osteoarthritis, and the neck is a common site of fracture, so that's why it's important clinically. As we move laterally, we'll get to the styloid process or base of the fifth metatarsal, which is where avulsion fractures commonly occur from really intense ankle sprains. It's also an insertion point of the fibularis brevis muscle. If we move kind of back up, we'll find the ATFL, which is the anterior talofibular ligament, which is the most commonly sprained most commonly sprained ligament in the ankle, and it connects the talus and the fibula bones. Now we will move over to this foot really quickly to do the medial structure, which is the navicular tuberosity. So as I slide down, I kind of slide off the medial malleolus, and the first prominent thing I feel right here is going to be the navicular tuberosity. This is important because it's an insertion point of the spring ligament in the foot. It is also something that can be commonly fractured or broken due to it sticking out. Now we're going to move up to Michael's shoulder quickly. So first, I'm going to find Michael's clavicle. I'm going to follow it out. And once I get to the end of his clavicle where it connects with the acromion process of the scapula, that's going to be his AC joint or acromioclavicular joint. When people have a shoulder separation, it's referred to as this joint being torn. It is also a site of inflammation as a result of that. And then after the AC joint, we're going to move now to the greater tuberosity of his humerus, which I can find about right there. Prominent structure right here on the front side of the humerus. This is where the biceps tendon will run through the intertrabecular groove between the greater and lesser tuberosities. It is also an insertion point for the rotator cuff muscles coming from his back. Next, we will have the subacromial space. So again, back up where the AC joint is, and then I can fall off. As I fall off the AC joint, there's a little space in there where the supraspinatus muscle is going to go into. There's also bursa in there, so it's a common site of impingement and shoulder pain, and that's the subacromial space. After that, we're going to come back to kind of the anterior side and palpate for his coracoid process of his scapula, which is right there. And the coracoid process is the insertion of the pec minor, and it's the origin of the coracobrachialis muscle running down the arm. While we're in this area, we're going to keep moving down Michael's arm. So first we're going to do the lateral epiconda of the humerus. So if I have Michael flex his arm, you can kind of see it sticking out right there. This is a common site of origin for Michael's wrist extensor. So can I have you do this with your wrist, Michael? So now I can feel those muscles flexing, and it's a common site also for tennis elbow when people have wrist extensor pathology or forearm extensor pathology. Moving to the medial side, I'll use your other arm. Moving to the medial side, here's the medial epiconda of the humerus, which is a common site of origin for Michael's wrist and forearm flexors. So if he flexes, I can feel those going. And also, kind of same thing. When baseball players get Tommy John surgery, they get it on this side, like the medial, collateral. The medial epicondyle of the humerus has those similar pathologies just on the medial side. Now we're going to move distally quickly. Actually, no, sorry. We're going to come back up here. We're going to do the radial head, which is right in this area. If I have Michael turn his hand like this while I'm holding it, I can feel it spinning in my hand. That's a common site of fractures. It sticks out as well in that area. It is also a spot where the annular ligament is what surrounds the radial head. So now we're going to move distally. Can I have Michael flex his thumb for me? So in this area, this is where Michael's scaphoid bone is going to be. It orients us to where his flexor or extensor pollicis longus and abductor pollicis muscles are going to be, because they surround the scaphoid bone in his anatomical snuff box. And this is a very commonly fractured bone in the wrist. I have Michael turn this way and find his triquetrum bone, which I can feel on both sides right here. His triquetrum bone is just distal to the ulnar styloid process of the ulna, which is right here, and between them is the ulnar collateral ligament. So it's a good structure to orient yourself on both of those. I'm going to have Michael relax now. Michael, can I have you spin around so I can do your back structures now? We're going to start with Michael's scapular spine, which is pretty easy to find if you palpate like this. It's just very prominent. The scapular spine is a good structure to know because above it you can palpate the supraspinatus and below it you can palpate the infraspinatus. After the scapular spine, you go to the inferior angle of the scapula, which is right here. You can just follow the border. And the inferior angle of the scapula lines up with T7 vertebrae. So if I move to the middle, I can orient myself with that. And the inferior angle of the scapula is also useful because if Michael had some serratus anterior weakness or had damage to his long thoracic nerve, his scapula would be winging where it would be sticking out kind of like this. So it's a good structure to know for that. After that, we're going to be moving to the spinous processes on the neck. So to start, we're just going to kind of come up here and try and find C2. C2 is the first palpable vertebrae. And you might have to push a little bit, which is kind of annoying because it might be kind of painful, but you can feel it right in there, Michael C2. And this is obviously important to know because it's the first palpable vertebrae, so you can count down the other vertebrae as you're moving down. And it also is the bone known as the axis, where Michael can have his node joint and shake his head back and forth because that will rotate around the dens. And then we're going to slide down. As I'm sliding down, palpating vertebrae, I'm sliding down the articular pillars and the facet joints, and the facet joints connect the vertebrae together, and the articular pillars are kind of spaces where ligaments running along the spine or like the spinalis muscles and stuff will run from his external occipital protuberance up here all the way down to his sacrum. As we keep moving down, you'll get to a very prominent vertebrae right here. This is known as your C7, and above it is your C6, or this is your C7, sorry, C7, C6. So if I have Michael flex his neck forward, the C7 sticks out a lot, so it's really easy to find that way. And if I have him stick his neck backwards, it kind of hides, but the C6 kind of sticks out a bit more. So common site for cervical disc herniation, lots of neck pain originates from this area. As I slide down, from C6 and C7, I can go and find the first rib, which is a very like kind of tough structure to palpate in this area because the trapezius can be really thick and Michael is huge. So I'm going to be pushing in through here, and I can kind of feel a hard end feel a little bit, and you have to make sure you're medial enough you're not on his scapula. But once you're hard and in there a bit, that's the first rib. This is where his scalene muscles in his neck are going to insert, and it also can orient you to move in and be like, all right, here's your T1 vertebrae.